Hello and welcome. This evening I'll be your host for what's going to be a really fascinating session. Many people working in IVF have spent a great deal of time and effort researching the embryo, and specifically its genetic or chromosomal status. And that's my special area of interest, so I'm really excited to be hosting this webinar this evening. Our last Ask Your Doctor session was about the endometrium, but today we're heading back towards the embryo. I'm joined tonight by a fantastic set of panelists who are here to help you better understand PGT-A and IVF, why, if, and when, and I would add, and a lot more besides. They are Dr. Àlex García-Faura, Scientific Director, Institut Marquès in Spain, Dr. Luca Gianaroli, Scientific Director at CISMA in Italy, and Dr. Elias Tsakos, Medical Director at Embryoclinic in Greece. And what we're going to do tonight is start by asking each of our panelists to answer one of three, I think, fundamental questions that will provide a brief introduction to tonight's topic. And then we'll answer your questions. So we do want to leave a lot of time to answer your questions. If we run out of questions, don't worry, I've got plenty to ask them. But I think it's really important to set the scene because we've learned that from previous sessions. If you want to ask a question, please put it in the Q&A box rather than the chat, because then we're more likely to get to it. And that will help us to deal with all of them. We'll try to answer all of the questions, but I will be prioritizing ones that are easy to generalize. So they're not necessarily your specific case. They haven't already been answered, and they pretty much stick to tonight's topic, just in the interest of time. And also at the end, I'll remind you at the end, but Caroline, our host, has asked me to remind you that in the poll section, there's a question about whether you are satisfied with the way we, the speakers, the panelists, how we provided the session today. Okay, so please go to that at the end. You don't need to do it now. So I'm going to start by asking Dr. Luca Gianaroli to explain what PGT-A is, very briefly and in a way we can all understand, because that sets the scene for tonight. Thank you, Luca.
Yes, sure. Okay. I think that you have to go back at least 20 or 30 years when we were trying to understand which was the best embryo to be transferred. And suddenly it has been known that some of the embryo or many of the embryos that we were transferring were not implanted because they were chromosomally abnormal. So the idea of PGT-A for aneuploidy, it was designed to remove from those embryos that should be transferred, those that are chromosomally abnormal, so that they would never implant, or if they implant, they would give, as a result, a miscarriage. So the technique implies a biopsy, like we do in most of the medical specialties, so removing few cells, and then make a genetic analysis that will confirm that this embryo is viable or this embryo is not viable. The state of the art is that at the moment we can predict the viability or not of an embryo based on the nuclear DNA normality, nothing else. So it's already a big improvement, but of course we should not be concerned if what we call a normal embryo, a euploid embryo, once it is transferred, could still take the risk of not being able to implant. With the technology that we have in our hands at the moment, this is proven to be an improvement, reducing the time to pregnancy, and Elias will tell more about the results. So this is the state of the art, and this is the most advantage, this selection criteria that now we have in a routine IVF and Dixie clinic.
Perfect, really succinct. Thank you very much, Luca. So that's kind of set the scene. And unless one of the other doctors has something, additional to add to that really changes that, then if they don't, we'll move on. And I'm going to ask Dr. Àlex to answer the question in general terms, and then I'm absolutely happy for you to give a specific for your clinic and your practice. And that is, who needs this test? When would you use it? Are there circumstances when you wouldn't use it? And then I definitely will ask all the other doctors, because I know there's differences between doctors and countries for this kind of test. So please, Dr. Àlex.
Thank you, Alan. Well, I think that this test should be used when we expect high risk of aneuploidy, of abnormal or chromosomical abnormal embryos, depending especially on the X age, so the female, the patient's age. And we know that this risk is raising starting at 35-year-old, where the risk is around 50%. It's really high in a 35-year-old patient. When we move up to 38, we might be around 70% of abnormal embryos coming from her eggs. And once we get up to 40, between 40 and 43, we might be moving on the range between 85 or 95% of abnormal embryos, especially when we get up to 43 or 44-year-old patients. So I think that the first group of patients that probably would need or require, would be recommended to use this test, are these patients trying to conceive through IVF, of course, between over 38-year-old. The second group, of course, would be younger patients or any patients that have had transfers or previous transfers in optimal conditions. And optimal, I mean a high quality day 5 embryo and perfect endometrium protocol, and still has had repeated failure or repeated miscarriage, even if getting on optimal conditions on the day of the transfer. So probably this would be the two major groups. And of course, there's a smaller group, which is when we do know that there is also high risk coming from the male factor. So we might expect in oligospermia or severe male factor a higher risk of abnormal embryos. So that would be a smaller group, but still an important group of patients that could have a repeated miscarriage or repeated failure if they don't undergo PGT-A. And the final group that we might be able to discuss later on is just because of the patient wants to make sure she's transferring an euploid embryo. But of course, I think that this last group, it's open for discussion later on.
Okay, thank you. That is really clear. Because I know there may be some differences with the other doctors, and we know there are differences around the world, either legal, regulatory ones, or belief, choice, and so on. Can I now ask Dr. Tsakos what your indications would be in your practice, but also whether there's any specific rules in Greece?
Well, thank you very much, and welcome everyone. And it's a great pleasure and honor to be amongst this panel tonight. I shouldn't forget to ask for autographs, Professor Gianaroli and Dr. Àlex García-Faura. It's a huge respect for both of you, and of course, thank you so much, Alan, for hosting this event. Essentially, just to bring a sigh of relief to our audience tonight, may I say that before we started, we had a little chat between us, and it seems that we all share the same principles and the same views on PGT-A testing indications and application and value, if you like. So I don't really have any much more to add to Professor Gianaroli or to Àlex, to Dr. Àlex García-Faura. All I was going to say is that apart from specific male factors, I would also include the male age as well, perhaps as a potential factor. I mean, these days we see more often men in their late 40s and sometimes in their 50s or 60s. So that by itself, in my opinion, should be an indication for an extra indication for PGT-A. Now, with regards to legislation and regulation in Greece, may I say that it's not brilliant at the moment, because it seems that the new data hasn't been incorporated into the legislation. So at the moment, we may only perform PGT-A on women over the age of 40 as a routine. That's the only absolute indication. And for younger women, they would have to go through either 2 miscarriages or 2 or 3 unsuccessful IVF implantation attempts. In my opinion, and if I'm allowed, I think I'd probably express the opinion of the majority of fertility specialists in Greece. This is not fair for our patients. It's not fair for a 39-year-old woman having to undergo 2 or 3 IVFs and having to experience 2 miscarriages before she qualifies for a test that's proven to be effective in her age group, and especially when she's also going to privately pay for this test, because this test, by and large, in Greece is not compensated by public or private insurance and so forth. So I'm very, very much of an advocate for the freedom to choose, and especially when it's based on scientific data.
Okay, perfect. Very clear. I'm going to ask you all a question at the end. Put you right on the fence on this one. But let's go to Dr. Luca Gianaroli. Can you just tell us what your indications are for PGT-A, please?
Generally speaking, I think that the indication is every subcategory of patients that has a higher risk of not getting what they want. That means a healthy baby. So all the indications that have been given by the colleagues, they are all right, but that also depends on the quality of the center. So if you have a very high percentage of clinical pregnancies or deliveries in your center, it's enough that they fail 2 or 3 times a normal embryo transfer, for which an indication can be given even in a young couple. Of course, if your results are not as good, maybe the repeated IVF failure, it would mean that they need more cycles before they enter the program. I think that the main factor play a very important role, because if you look into the sperm with a fish analysis, so you look into the chromosomes of the sperm, you see that many times these men with a very poor sperm quality, they also are having a high percentage of chromosomally abnormal sperm that will contribute to chromosomal abnormalities or to chromosomal defects in the newborn. Just to give you an idea, if you are very severe malfactor, the Down syndrome risk is multiplied by 3 or 4 according to the quality of the sperm, independently of the age of the mother. So there are signals quite clear for which everything that is getting out from the normal range maybe should, in one way or another, have a deselection of the embryos. To make an embryo transfer where an embryo is unavailable to implant is almost a more, let's say, a bad clinical practice. You shouldn't do that. And at the moment, PGT-A is one of the most powerful instruments that we have in our hands to remove the reproductive circuit those embryos that would never implant, so they should not be transferred.
Okay, just coming off mute. Thank you very much. So that question I was going to ask that is linked to this one, and we'll just do it quickly, and then we'll move on to the next question, and then we'll get on to patient questions. I see them coming in now. So if I can ask Dr. Àlex, who would you definitely not offer it to? So I'm not talking about the patient that says, I want it. They haven't said they want it, but you're looking at them thinking, I don't think it's indicated here. What would that patient be?
Well, of course, I think that the first group of patients is patients that do not even need IVF. No? And sometimes some patients are moving up to IVF too fast just because some of the easy techniques do have a low efficiency or a low pregnancy rate, and perhaps not in Europe. In some other parts of the world, you see, scientific works with the mean age for IVF is 27. So, of course, for these groups that should try naturally or should try with easier techniques like artificial insemination, of course, they don't even need to go up to IVF to be able to do PGT-A. But of course, I think that we cannot only focus on the medical part, and we need to focus on the emotional part. And I think that's quite important too. It's not the same to attend a patient that has not even tried to conceive or to get pregnant, or the patient that has had 4 previous spontaneous miscarriages without any artificial reproductive technique. So, of course, the impact of, or the risk of having again another miscarriage, or a patient that has had a previous pregnancy interruption because there was a chromosomal abnormality, even if they were very young and with no risk, I think that we cannot say no just because of the medical part. Sometimes we need to listen and make sure that that patient, from an emotional point of view, couldn't stand another miscarriage that could have been prevented, or another baby with a chromosomical abnormality that would have been tested and avoided. So I think that, of course, we're setting only the medical criteria, but I think that we do all agree that, first of all, we need to listen, and then we need to talk.
Okay, excellent. Thank you. That's really helpful. I'm sure everyone will find that helpful. Luca, is there any group that you know, if it hasn't already been said, but do you want to reiterate patients for whom you don't really think PGT-A is indicated?
There is a group of patients that sometimes they're missed out, mainly those with, again, male factor where chromosomal analysis has not been done. I'm talking about karyotype. If you do peripheral karyotype, you find that at least 5% of them have translocations. This is not PGT-A, but again, if you look at the translocated males, the chance for them to have a euploid embryo is extremely low, depending on the translocation. So it would be extremely important that when we have a severe male factor and the origin of this is not well known, that we karyotype the patients. And if we find any abnormality in the karyotype, PGT-A, not only for the translocation, but PGT-A in general should be done. Because we will find a lot of chromosomal abnormalities that do not refer specifically to the translocated chromosomes. And that will, again, decrease the chance of pregnancy. So PGT-A should always be back-to-back when we have problems like karyotype abnormalities, or even when we have monogenic problems. So when we have genetic diseases, it would be a pity to transfer an embryo that is safe for the disease that we are looking for, cystic fibrosis, hemophilia, whatever, and then we have a chromosomal abnormalities that brings them to a miscarriage, or even worse, to a Down syndrome baby. So this is another strong indication for PGT-A.
Okay, thank you. Dr. Tsakos, is there a group of patients, we were talking about it before we came on air, is there a group of patients that you think probably shouldn't be, regardless of the law or the regulations, that probably shouldn't be offered PGT-A as a front line? I think you mentioned something about egg donation, and I think that's useful for the audience, because I was speaking to a patient this morning, you know, in a coaching environment, and they were saying they feel like lots of things are just boxes are being ticked. You know, we're being asked to do this, and they don't necessarily feel a lot of thought is going into it. So do you want to say something about egg donation, perhaps?
Sure. I fully agree with what's been said already. And yeah, I would add the egg donation patients where perhaps PGT-A would not be indicated, provided that the sperm, the male partner who's providing the sperm is of normal age, reasonable age, which is probably under the age of 45 to start with no severe male factor that would indicate further analysis. So yeah, egg donation is a group of patients that I would not consider PGT-A as first line. Having said that, I mean, you know, we've all seen egg donation cycles failing. I mean, it's a small percentage, but you know, although we're spoiled with egg donation success rates, with cumulative success rate, you know, reaching up to 90% per egg donation cycle, I think for those unexpected failures, especially if there's a suspicion of potential male contribution to genetic anomaly, I think it may be indicated.
Okay, thank you. That is super clear, super helpful. So we're going to stick with you now, because you got the third question of the basic questions, and then we'll move on to the audience questions. So your question is about what kind of results might we expect, and if you would also cover, because this will be, I guess, personal experience of tests you've offered and results you've got, if you can cover what percentage of samples, let's call it samples, embryos, you expect to not get a result or to get a result, whichever way you want to say it, and then the kind of results we might expect. So, you know, the basic categories of result and what they mean, please.
Sure. I mean, in lay terms, there's 4 types of results I would expect. One is a normal result. So that's a normal euploid embryo. Second is an abnormal result. So white, black, abnormal, totally abnormal result. Then we have the gray area, and gray could be either light gray or dark gray. And I'm referring to mosaicism at this stage. And then there's a small possibility, but existent, of no result, so unable to get a result from the lab. And that's why, I mean, the types of results that may be expected, in my opinion, is part of the complexity of PGT-A, is one of the reasons why PGT-A probably got a bad name, especially with the regulators, especially if the regulators, they don't really consult fertility specialists very closely. And I think as fertility specialists, we have to put a lot of effort into counseling our patients, our couples, our single women, before PGT-A is performed, in order to cover those potential possibilities.
Okay, perfect. And I will ask the other guys as well. But and you know, give an honest result of what you see rather than aspirational result. What would be the kind of average no result rate, or you can put it the other way, you expect to see results in what percentage of samples that you send off? Because I think that's an important expectation management thing. And also, if you can talk about survival of biopsy, because it is an invasive procedure, but it's been shown to be effective. So those are questions that often patients ask, and I know you guys know that. So if you wouldn't mind saying what you would expect to see in a reasonable practice.
Well, okay, if I can say something is embryo biopsy technically is a surgical procedure. And as any surgical procedure, need to be done by expert people. And to be an expert, you need to have a learning curve that will put you in training via models, animal trials, or whatever. So first of all, let's say that embryo biopsy, it has to be done by expert people. Second thing is that in general, in any branch of medicine, when you talk about adds-on, you consider adds-on as an improvement of the technique. Only in reproductive medicine, recently, adds-on have been considered from a negative point of view, because it's something that people are doing just to increase not only the result, but to have some economical return. And this has been said in many scientific papers, in many discussions. What I want to stress is that PGT-A is not an adds-on. If it's done properly, if it's done consciously, if it's done scientifically correctly, is a big help to reduce time to pregnancy and to avoid unnecessary embryo transfers that mean cost, stress, and economical burden to the patients. I'm saying this because I want to remove PGT-A from a negative viewpoint of being an adds-on that has been offered only to get some extra advantage to the clinic. This is completely false. Scientific data are showing this clearly. So it has to be done properly. To conclude, it has to be done by professional people, but it is an help for couples, not an adds-on to look for extra money for the clinics.
Yeah, and I appreciate you saying that, because you're absolutely right. A lot of these new techniques, these innovations, have been categorized negatively. But if you wouldn't mind giving us what you think is a reasonable percentage, because I think those are the sort of questions that patients ask as well. Are all of my embryos going to survive? Is it 100%? Is it 98%? And how many are going to give me results? I know it varies, but can you give a kind of average?
99% of the embryos will survive. And if those that do not survive, they would probably not survive even if biopsy has not been done. And secondly, the answer is covering more than 98, 99%. And if you have no answer, this does not prevent you from not doing another biopsy. I think that we are going to publish an embryo that has been biopsied 3 times, because it was the only embryo that the patient had, and she asked us to do this, even if we explained to her that nobody has published up to now 3 embryo biopsies in the same embryos, and now she's delivering a normal, healthy baby. So as far as, again, you are doing this professionally with the right person, the biopsy by itself would not harm the embryo.
Okay, thank you. So, I mean, we can sort of generalize and conclude from that when people see, I mean, I could ask the other guys what percentage they're looking for, but I think you want to say something lower because that wouldn't look good. But I think the reality is when it is lower, it probably points to a problem, right? So if you go to a clinic, and I always say to patients, ask all these questions. If you go to a clinic and they say, and you ask the question, what's your no result rate? And they say, oh, it's about 10%, the alarm bells should be ringing, right? Because maybe it's not being done in a professional way. Àlex, please.
Well, I think that Elias was just raising his hand before. Please, Elias, go.
Okay, Elias, go ahead.
Thank you so much. I mean, I fully agree with Prof. Gianaroli. I mean, I would only add, if I may, that 99% survival is the provision for getting 99% survival is, of course, top quality lab and top quality embryologist, and also selecting top quality blastocysts for freezing. I think this is a very important point, and may I express a little bit of my own personal bitterness, if you like. I mean, in our lab and in all of the labs I've worked in the last 30 years that I'm in the field, our embryologists have been very selective what they put in the cryo storage, and that has caused a lot of issues sometimes with patients when they say, oh, how come I only have 3 blastocysts out of 8 eggs and so forth. So I think we could all agree, I'm sure, that we only freeze, we only grade blastocysts, and only good quality or top quality blastocysts are utilized.
That's a really excellent point, because as you know, patients understandably get very attached to numbers, and once they think there are a certain number of embryos available, it's always a surprise and a disappointment for that number to go down. But it is a balancing act, as you know. So if you don't biopsy an embryo, it's probably because you think it's not going to survive, not going to give a good result, not turn into a healthy pregnancy. But you have potentially removed a chance by not biopsying it, because it usually has no further part to play in the cycle. Àlex, did you have something to add, please?
Yes, well, of course, first of all, I think we do all agree. The embryos that will not survive will be the abnormal ones. Before, after, during biopsy, usually there are the aneuploid ones that will get blocked. And of course, I think that's because of this chromosomical abnormality. And referred to the results that we might have, I think that right now, and especially in the UK, you have an extra result that I still don't know if it's an add-on or that we will be able to use it, which is this aneuploidy is coming from one side or the other one. No, so we can get to know right now whether this chromosomical abnormality, if there is only one, is coming from sperm or is coming from the egg. I think that we do know that most of the trisomies, and that's quite standard, are coming from the egg, most of them, and most of the segmental, so a part of the chromosome is lacking. Most of them are coming from the male factor, but we do know that some labs now are offering, and I think that we still need some extra evidence to make sure that this is okay. But I think it's quite important when we do have both a male and an egg factor to get this information, whether the most or the majority of the embryos are abnormal because of the eggs, or the majority of these embryos are abnormal because of sperm, before deciding changing to egg donation or sperm donation in the same couple. Okay,
perfect. Thank you for that. Let's stick with you, Àlex, for a second. Let's do our first patient question. I'm just going to, sorry, I have to do a little digital thing, click it to say which question we're talking about. Are there any downsides of taking these tests? Okay, now we may have already covered it, but if you can sort of briefly say what potential downsides there are. So, in medical terms, we say side effects, don't we? But, what are the potential downsides? And why aren't they part of the standard protocol? And I think there will be more discussion, so I will come to the other doctors on this one.
Well, I think that the first thing we should say is, if it was for free, probably we would do it more often. That's the worst side effect. I think it's the cost. And some patients that could have the possibility to have 2 or 3 attempts, sometimes they won't, because they need to afford PGT-A added to the IVF treatment. But I think it's quite important to say that the most expensive treatment is transferring an abnormal embryo that will never lead to a delivery. So when patients say, what's the worst part of it? I say, sorry, the worst part is the economical part, but just need to think that it's still worse to keep on freezing and transferring 2, 3, 4, 5 high quality blastocysts, all of them abnormal. That's really that's more expensive than any PGT-A fees that you can get on any clinic. So I think that step one is, I'm sorry, we know what we're looking at the medical part, but I think that talking about money is also important for patients. And the other thing, of course, is that we cannot do the transfer immediately. No, we need to freeze the embryos. There's going to be a few weeks delay. But of course, this will also give us the possibility on the following cycle to do the optimal protocol to increase implantation rate. So yes, we cannot transfer the embryo on that cycle. We need to wait for the next one. But of course, this will lead us also to an optimal endometrial protocol for endometrial prep.
Okay, perfect. So that's given us a couple of downsides, and they're really clear.
Can I just make a very brief comment?
Go ahead, please.
What Àlex said is the best scenario. The worst scenario is without having a PGT-A, a patient over 38 have a high chance to have a miscarriage. A miscarriage is a waste of time, a waste of energy, and many times this patient just drop out from a program. And this is the worst thing that could happen to an infertile couple that have looked for babies for many, many years, just to abandon on the basis of a miscarriage. So I feel guilty every time I see a miscarriage after PGT has not been performed, because I know that that couple is going to pay such a high price that the major risk is that they abandon the program. And this is our fault, not suggesting them a PGT-A.
Okay, but could you give us that's like, you know, the argument for doing PGT-A, and that's fine. You know, we need to know all those things, but we also need to know what are the potential downsides of doing it, because there are potential downsides, and we've sort of discussed them in a tangential way. So even though they might be low risk, what are the downsides, please? Or are there no downsides? Luca.
It's very, I think that Àlex is right. The major downside is the costs, but that's imply that we should have an agreement among clinics and also industries, because we know very well that the cost is not mainly driven by clinics, but is mainly driven by genetic laboratories and the industries. So maybe you should find a solution for which this is going to be cheaper, is going to be not safer because it's already safe enough. It's going to be cheaper. We need to use this tool for many categories of patients that deserve it without having the constriction of the costs. That is the reality.
Okay. Thank you for that. Elias.
Elias says.
Yeah.
Sure. Thank you. I fully agree with both of my colleagues. The only thing I would add is that the cost is a downside if it's not applied properly. If it is applied properly, I do not believe that the cost is a downside. Because if you take into account exactly what Professor Gianaroli said and what Dr. Faura said, that, every time I have a miscarriage, to be honest, I feel very guilty, not just guilty, when I know I could have prevented it. And in Greece is even more frustrating because we are bound by law. We have a 39-year-old woman with a very low ovarian reserve. We managed to create maybe 2 blastocysts with a husband who is in the mid-50s with terrible sperm. We know that the chance of chromosomal anomaly is probably as high as 80%. And this woman has a miscarriage and then she drops out of IVF altogether. And it's happened to me many times. And, I'm grateful to Professor Gianaroli who brought this up. As a fertility specialist, we have feelings as well. And what I find is that the older we get, the more feelings we have. And it's very frustrating, dear panelists, Dr. Alan, and dear audience, very frustrating for a doctor not to be able to provide the very best possible treatment to their patients with a technology that's been there for longer than 25 years, 30 years.
Okay, thank you. Let's close that question for now, because all right, and move on to another question. Sorry, I'm just trying to. There we go. Yeah. Let me just find another one. That's age limits. Okay, so somebody asked in the chat, but it was meant to go in the questions about not being able to do it in a certain country. So a lady here has had a number of different transfers. Some are successful, some not successful, but she's in Sweden and they're not allowed to do PGT-A testing. So do you think it's worth traveling overseas, taking those, because those embryos exist, taking those embryos overseas and testing them? And if you do, then you would have to convince her that the live birth rate increases by doing PGT-A. And this is where you can use that, you have to be subtle about how we describe the success rates. Dr. Àlex, can I ask you to answer that one, please? And, how would you convince someone to bring those embryos over and test them?
Well, of course, when we look at cumulative live birth rates, we cannot tell that PGT-A will increase the possibility of a live birth rate if we transfer all the embryos one by one. And that's why some countries like France won't even allow PGT-A at all. So if Dr. Tsakos was frustrated just thinking our colleagues in France that are not allowed to do any PGT-A at all, okay? But of course, I think that the main point is time to delivery and avoiding unnecessary treatments. Of course, as we said, if we can select the embryo that itself has the possibility for pregnancy and delivery and avoid transferring these embryos that won't even implant or will lead us to early miscarriage or monosomy or trisomy during pregnancy, of course, I think it's worth it to test the embryos and avoid 5, 6, 7 unnecessary transfers that will never lead us to the birth of a healthy baby. So, of course, yes, I think that we cannot tell that if we transfer them all one by one, we will increase the overall newborn rate. But some of these patients will get exhausted and will abandon after the 3rd, 4th, or 5th transfer, exhausted physically, emotionally, economically. So yes, I think it's important to avoid these unnecessary treatments, because we might get a high rate of dropout patients that will abandon just because they are exhausted from any reason, and that still haven't had the possibility to transfer the only euploid embryo that they had in that group. So yeah, I think it's worth it.
Okay, thank you. We'll move on. I know you've probably all got something to say on this, but I think that's a really clear answer. So here's a really good question, because this comes up a lot in coaching, where somebody's been told, I've got one blastocyst and I've heard it's a selection technique, so I shouldn't do PGT-A. Luca, would you mind answering this one, whether you think there's any scenario in which doing PGT-A on a single embryo has merit?
I think it does, based on what we have just heard about the unnecessary embryo transfer. I mean, if you have a chromosomally abnormal embryo, honestly, from the medical point of view, don't you consider yourself completely unethical to transfer an embryo that you know that will never be able to succeed in terms of full-term pregnancy? And in the meantime, I like to underline what Àlex has just said. If you look inside our cryobanks, how many euploid embryos are sitting there without knowing that they are euploid because the patient just disappeared, because they just left the program, didn't left the clinic that is acceptable. They left the reproductive program that they had in their mind. So they abandoned the concept to be parents on the basis of the fact that they have done a certain number of embryo transfer for nothing. I think this is an ethical issue that should be deeply discussed, because we are responsible of those patients who abandon the program, leaving in our bank euploid embryos that could give rise to a normal, healthy baby. So on the basis of this, I think is even only one embryo has the right to be tested. The point I want to make is that we should think differently. So we should reverse the paradigm and say, madam, because of your age, because of your history, because of your clinical problems, we need you give to us a certain number of embryos, and among them, you will have 1 or 2 or 3 embryos transferred because they will be normal. How many embryos we need to reach this point, we roughly know, and that implies that we need a large amount of eggs. Are you prepared to do 1, 2, 3 ovocyte recovery to reach 4 or 5 blastocysts, and among them discover that 1 or 2 are available for transfer? This is the engagement that we should have with the couples. Stop saying you got 30% per cycle, 40% of cycle. This doesn't mean anything. We need to reverse the paradigm and say to them, you want 70%, 60% of delivery? We need 3 normal blastocysts. That means you have to give to us 6, 7, 8 blastocysts. That means that you need to give to us 30, 40 eggs. It doesn't matter how many ovocyte recovery we need, as far as you give to us 30 or 40 eggs. If we are able to explain to patients that this is the way to go, now we are getting very close to oncologists. If one of us, touching wood, has been told that we have a cancer and we need 6 chemotherapy cycles, there is no reason to do only 1 cycle, because we will never get rid of the cancer and we'll have all the collateral effect, all the negative effect, losing hair, vomiting, or whatever. All of us that have been told you have a cancer, you need 6 treatment chemotherapy cycles, all of us will do. And we need to convince the patient the same way.
Thank you. That's really
helpful. No, I know that you're not thanking me, but anyways, that's...
Well, thank you for explaining it, because I come up against this a lot, where people say, I've got 1 embryo, and some of the people in the clinic will say, oh, I wouldn't bother. And they get fixated on the cost then. And I'm not saying, we've all said it's expensive, right? And I no longer work for industry, so please don't ask me to reduce the price, because I don't work for industry anymore. But I understand it's expensive. But I've always, when I was working in the lab, I always would say to my team, when they said, oh, it's a bit expensive to do such and such a technique or whatever, I'd say, is it worth doing? That's the first question. If it's not worth doing, it doesn't matter how much it is. So we have to establish that first. But thank you for that. That's really clear. So now I've got a question for Dr. Tsakos. This one should be pretty straightforward, and you can use your own practice to answer this one. Is ICSI compatible with PGT-A?
Yes.
Yeah, that's really simple. But I'm going to ask you an extra bit to that, because lots of clinics, as you know, will say it's mandatory for PGT-A. And so what's your feeling about doing, if somebody doesn't have a male factor problem, they would normally have conventional IVF. Is that still compatible with PGT-A in your practice, at least?
Yes.
Okay. And I just want to, and you have to give me a yes or no answer, not a long answer.
That's why I try to keep it as simple as possible.
No, you've done a fantastic job. Other doctors, do you allow IVF for PGT-A as well, or is it always ICSI?
We only do ICSI.
You only do ICSI, okay. And Luca, what's your approach with this?
Yeah, I agree. For PGT-A, we do ICSI.
Okay. And the only reason I ask is because, sometimes people do ICSI anyway, irrespective of PGT-A, but there are some papers out recently showing that there doesn't seem to be a problem with doing IVF, because, one of the problems is worrying about contamination from the sperm. We won't get into that now, because that's quite a complex subject. So we've finished with that question. That was a great question. Thank you. So it's certainly compatible with it. I'll come to that one in a second. So can I ask, I think, Àlex, you're a good person to answer this one. I'm sure you've all got answers to this, but you mentioned it in our little chat beforehand. So let's say we have a euploid embryo. We've tested the embryo. It's euploid. We're really happy with it. It looks really clear, and it doesn't work. And maybe we transfer multiple euploid embryos on different cycles. what would you have done in advance, or what would you now do to try to improve their chances? Because, you know, it's not all about the embryo.
I think that right now we can say that the gold standard, or what we all would like to transfer, is a single euploid high quality embryo. That would be the optimal condition for any clinician or any patient. And I think that also in clinical trials, that what we are trying to look at, this profile of patients that have had one single high quality blastocyst transferred. But of course, sometimes it fails. We know that probably newborn rate, the possibility of getting up to delivery, depending on the clinics, might be between 60 or 65% per one single blastocyst. And this is, of course, in relation to repeated implantation failure, what I said before, in optimal conditions. But of course, what is repeated implantation failure for the clinician, and what is repeated implantation failure for the patient? So our patients on the first attempt with a high quality normal embryo will say, we need to do something. No, it didn't work. What can we do? Can we get several add-ons that Dr. Gianaroli just explained before? I think that we need to be honest and true. And when we call repeated miscarriage or repeated implantation failure, it's because we have more than one. So I think, first of all, we need to tell the patient that it's normal, just for statistics, that having a single embryo transfer that has been tested is not a disaster, and that we do not need to start undergoing invasive, expensive, and sometimes with low scientific evidence tests just because they had one single transfer in optimal conditions that didn't work. I think that with euploid embryos, and as I said, with a beautiful lining and everything okay, and all the parameters correct, of course, if we do have a second attempt in this optimal condition and with an euploid embryo, probably we need to start doing some tests related to the uterine cavity, and I'm talking about morphology. Now, some of the tests that have been used in Europe the recent years, and that unfortunately do not have strong scientific evidence, and sometimes also some studies related to autoimmunity or thrombophilia that are quite easy to do, and that have scientific evidence to support that this might help us better understand why did we have repeated miscarriage or repeated failure.
Okay, thank you very much for that. That's really clear. In the interest of time, I want to cover at least two more questions. So, and you're probably all going to get a chance to give some view on this as well. But I'm going to go to Dr. Tsakos now and ask the question. Well, I want to make a comment first. I asked earlier about, what are the downsides, and I think, and I'm a believer in PGT-A, I believe it works, but I think one of the downsides in recent history has been this gray area, and you very nicely described it, Elias, this, light gray, dark gray, the mosaics. And the truth is, and Dr. Àlex made a very good point, that sometimes it's not biology or medicine, it's psychology that drives things. So when someone sees something that's not quite normal, sometimes they don't transfer it, whether that's a doctor or a patient. So I would say that one of the downsides of PGT-A has been that not every embryo that comes back as slightly different gets transferred. So that is a bad thing. So, I want to just put that out there because I don't think anyone can disagree with that. But what I'm going to ask is, what's your policy on transferring mosaic embryos in your clinic? Because I think, patients are going to get those results still. So what would you do in your clinic? And then I will ask each of the doctors to tell me what they do.
Firstly, we have spoken about it. We have counseled our patients beforehand so that they're a little bit prepared about this potential possibility. Secondly, of course, we give priority to the euploid, to the normal embryos. And, usually we have good results with those. And then if it comes down to the remaining embryo being mosaic, then we assess it, we look at it again. We have a multidisciplinary meeting with the embryologists, the clinicians, the genetics lab, the patients, and then we decide if it's a low-grade mosaicism, we may consider transferring it. If not, then we put it on hold. It has to do also with the option given to the patients whether they would consider another stimulation in order to, to solve the problem at the time. So all in all, we leave them for last, mosaic embryos. If the low-grade mosaicism, and if the patients are not willing to undergo another stimulation, then following very careful second counseling, we may consider transfer.
Okay, thank you very much. Luca, could you tell me what you would do with mosaic embryos, please?
Okay. First of all, I'd like to remind you that when we were using the previous technique that was microarray, and when you were not able to detect mosaicism, and you look to the big registries, European registries, national registries, you don't see any difference in terms of risk of chromosomally abnormal embryos that have been implanted and that have gone to term or that have been miscarried. This does mean that the importance of mosaicism is very limited. It goes down to 2-3%. So if we have from the genetic lab answer regarding mosaicisms that involve the high majority of the cells, those chromosomes that could lead to miscarriage or to a trisomy, and I'm referring to chromosome 16, 21, 22, 13, and 18, we will not transfer. All the rest, I think it makes sense to transfer as far as the patient is aware that the chance of pregnancy is diminished and maybe the chance of miscarriage is increased. And I think this is the right way to say, because once again, when we look at the 100,000 of cycles with microarray, and you compare to the 100,000 of the new generation sequences that have been done, in fact, you don't have an increase of malformation and chromosomal abnormalities fetus. Mm-hmm. So my point is that we have emphasized from the clinical point of view the mosaicism as a sort of biological, I don't want to say artifact, but a biological event that is not confirmed by the clinical event of a normal pregnancy. So, in other words, I will not be worried.
Okay, thank you very much. That's really clear and really important information. Dr. Àlex, is there anything you would like to add to that and tell me?
Well, of course, just adding, I completely agree with both of them. I think that, first of all, we need to tell patients that probably we are transferring mosaic embryos that are classified in the euploid group. Okay, so because when we say 10%, 20%, or 50% of the cells are abnormal, we're not going to be taking 100 cells. So probably we'll be taking only 8 cells or 10 cells. So every lab and every clinic should settle the cutoff point for mosaicism. But first of all, letting patients to know that some of these euploid embryos, of course, will be mosaic, and it doesn't have any impact. And refer to low-risk mosaicism. I don't go deep on that, but just saying that with low-risk mosaicism, delivery rate of this type of mosaic embryos is 40%. So it's quite a high possibility compared to the 60-65 of an euploid embryo. So I think, I don't know if it's worth it to transfer, but it's worth it to discuss and have time enough to tell the patient what this means, instead of saying just the risk of having an abnormal or an euploid baby. So I think that, of course, avoiding these high-risk chromosomes, 13, 18, 21, that's for sure that no patient will accept to get this transferred. But with all the other ones, I think it's very important for each clinic to settle, depending on the experience of the clinic and the miscarriage rate on euploid embryos of each clinic, should decide to raise or get down the cutoff point for mosaicism to make sure that we can transfer it.
Perfect. That's super helpful. I'm really grateful. We are really grateful for your time today, and we know that some of you need to leave fairly soon. Probably got patients to see and so on. So we're going to round this off by asking 3 different questions. And again, if you've got something extra to add, please feel free to sort of shout out. But I'm gonna sort of target the questions based on conversations we've had. I think you've all got an opinion on this, and I think those opinions are valid. But let's start with Àlex. You mentioned during part of this discussion, we're going to talk about the future now. What the future looks like. So you mentioned about potentially being able to look at the origin of the abnormality, so coming from either sperm or egg. So do you want to say a little bit about that, and what those tests might look like, because not everybody's offering that test. So if you say a bit about that, and then I'm going to come to Luca for non-invasive, because I know that's something you've got some experience with. And then finally, I'm going to come to Elias for any cost models that might make this more accessible for patients, please. So let's start with Àlex, please.
Okay, I think that especially for this group of patients where there's a low risk for aneuploidy, so a young mother and a male patient that doesn't have any sperm problem, and especially for these patients that have had repeated failure and repeated miscarriage, and we really do not know why. I think that, of course, getting to know if they do have a high a high rate of aneuploidy is important, but seeing that we do not know why, because it shouldn't come from the egg because it's a 25-year-old patient, and it should not come from the sperm because sperm quality is fantastic, and even fish or fragmentation tests are completely normal. We do know that still it might be something that we don't know why. It's raising the risk for aneuploidy coming from sperm or coming from the eggs. Usually it happens with the male factor, no? Even if with a normal sperm count, and sometimes even with a normal fish test that Dr. Gianaroli told before, there's still 40% of these patients that might have the risk of a higher aneuploidy rate, even of all the tests that have been done before are abnormal. So getting to know if this risk of these chromosomical abnormalities are coming from sperm or are coming from the eggs, and especially for these patients that all the embryos are abnormal, aneuploid, I think it's quite important to get to know which ones should we change, no, or go to egg or sperm donation. And it would be, I'm not saying it's the standard. I think we do all know that some laboratories will give us this opportunity, but I think there's still a lot of research that has to be done. But I think it can be interesting for this group of patients to help deciding whether we should change the eggs or the sperm.
Okay, thank you. Luca, do you want to say a little bit about, and you've got a long research history in this, but sort of very briefly, what are the what's the future looking like for a non-invasive test? So not having to biopsy the embryo and somehow get information to prioritize embryos, not necessarily select, but prioritize.
Yeah, I think that you said the right word. Non-invasive PGT has been tried since many years. We tried with blastocellular fluid that is semi-invasive, and now there is this new wave of checking the quality of the embryos via the spent media. At the moment, what we call the concordance rate, that means an agreement of the result with the gold standard technique, that at this moment, and I disagree, anyway, the gold standard is the trophectoderm biopsy, is still 90, 88, 90%. What does it mean? That 1 out of 10 analysis is not telling to the patient the truth. So would you accept in your life to have a diagnosis that fails 1 time out of 10? The answer would be no. I would never accept this as a test. So as far as we don't call a diagnosis, but we call, as you have said, a way to prioritize the embryos to be transferred, is acceptable. But we have to keep in mind that it's not a diagnostic test. The diagnostic test is always the test that is coming as close as possible to the truth, to the reality. And at the moment, we only have the invasive technique. Now, if we say that the invasive technique is safe because it's performed properly. If I want to have a diagnosis of my embryos, I would go for the invasive technique. If I am young and I have 10 blastocysts and I want to prioritize them and said, since all of them look morphologically equal, I would prefer that one that is telling me that in the spent medium it's okay, fine. It's not a diagnosis, it's not a test, it's a prioritization system. So as far as the patients understand this very clearly, I have nothing against, but don't call them this PGT. Don't call them tests. They are not tests. They are just priority tests.
Okay, thank you.
And by the way, I have to leave you. I'm sorry, but I have to leave you.
All right. Well, thank you, Luca. We're all grateful for your time. I am, the other doctors are, and I'm sure the patients are. So thanks very much. And if you close off now, then we won't see you doing your business anymore. Thanks, Luca. So the final question, and I'm sure Àlex will have an opinion too. I'm going to put it to Dr. Tsakos first, though, is, what can change in terms of costs and pricing models to make PGT-A more accessible? Let's make the assumption that it's a good thing to do. Let's just start with that, and then talk about how we can make it more accessible. Because we've heard a lot today from you guys, and of course I hear it from patients as well, that PGT-A is too expensive. So what would be your magic wand scenario? But you can't say it's free. Okay, that's not helpful. I think you're on mute.
Thanks for the question. It's a very difficult one.
I know.
Because, we all know that, let's not talk about other parts of the world, but even in Europe, there's a huge variation in costs. So we all know that. So for me, it's very difficult to, to speak on behalf of other European countries apart from Greece. So if I can speak about Greece, I can say this, that, cost of IVF in Greece has been the same in the last 20 to 25 years. And I was very happy to hear Àlex say that. I don't know if I understood correctly, but did you say that you usually do ICSI generally, or you usually do ICSI
generally? Yes, as a routine. Yeah.
I'm very happy I hear this, and because that's more or less what we do as well. And most people don't agree with that, don't accept it, or they don't do it. So I'm glad you do it. What I don't know is whether you charge extra for it or not. We don't.
No.
Excellent. Spain and Greece, we share common ethos and common wish to give the very best to our patients. So basically, to conclude, I would say that in Greece, regarding cost, in Greece, we don't charge extra for any laboratory technique really that would potentially increase the chance of the patient to get pregnant. So, there's no different price for ICSI versus IVF. IVF stroke ICSI is the same package. And also, if we need to do anything extra in the lab, like blastocyst culture, like assisted hatching, like time lapse, like embryo glue, there's no extra charge. So in terms of cost, all I can say is that in Greece, and certainly in my clinic and in the clinics I have worked in the last 25 years, there's the same price for ICSI or IVF. And that price has not increased in the last 20 to 25 years, despite the inflation and all that. So in this context, you understand that, the cost, it's not how much it costs, it's whether it's cost effective or not. And before we answer that, we have to answer whether it's medically indicated or not, and whether it is going to give us one of those three advantages that PGT-A should have, which is improve the implantation, the pregnancy rate per embryo transfer, decrease the miscarriage rate, and thirdly, shorten the time to pregnancy. So if the answer to those questions is yes, then yes, it is cost effective, and that is the approach that I have as a doctor, and that we have in my clinic, and I'm sure that Àlex will probably share the same.
Okay, let's let Àlex say his thing, and then I'm going to put you both on the spot and say you need to tell me what needs to happen to make this available to everybody, if that's what you believe needs to happen. Okay.
Let me just give you a tip. Do you know what an iPhone is?
An iPhone, yes.
All of us. Do you think iPhone prices are dropping down?
Oh.
Why? Because every single year there's an upgrade and makes better camera, higher pixels, higher RAM, a better phone. And who's going to use an iPhone 4 today? No one. So I think the same thing is happening and has been happening through these 20 years of PGT-A, starting on day 3 biopsy, arrays, NGS, and now parenting, whether this thing is going to come. So unfortunately, and that's not, this doesn't have to do with the clinicians, this has to do with the labs. And not because it's fancy, it's because it's effective. Okay, I think the main difference, I'm sorry, I don't want to just make a joke, but just to make people understand why these prices are not going to drop down. I think it's easier to tell it this way. But of course, it's not because it's fancy. It's because we're going to get more information, more accurate, and it's going to help us to teach the patients where the problem is and what are the possibilities of pregnancy and newborn weight with this group of embryos that the patient has. So of course, I think that the pricing will stay there. And of course, it will stay there. It's been there for 20 years and it's going to be there for extra 10, 20 years. But of course, we will reduce probably the risk, the non-informative rate. No, all of them will be informative. And we will be able then not only to test chromosomes, but we'll be able to test 10 genes, and then we'll be able to test 100 genes. So there's always going to be extra stuff to add to PGT-A. So I think it's not going to get down.
Okay, that's a wonderful answer, Àlex. I'm not going to ask. It is a wonderful answer. It's because there's a lot of truth in it. Okay, the only thing I'm going to sort of leave the audience with is just to say there are 3 components to the cost of delivering PGT-A. One happens in the clinic. I'm not going to make comments about it, but it's a fee for service because it's not being included as standard in most clinics. There's a cost of the people who do the test, so that requires some cost as well. And then there's the people who make the tests. And so there's 3 components to that cost. So I used to be one of the people who sold developed and sold the test.
Yeah.
And people would say to us, well, you should be giving it for free. I mean, come on, let's be realistic. But I said, even if I gave it you for free, you're not going to deliver it for free. All right. So I just want to, I want to be clear that as long as we are delivering something of value to patients, then there will always be a cost. And as you said, as it gets better, sometimes the cost stays the same or goes up. But let's finish with this one question then. What do you think is required, as briefly as possible? What do you think is required to make this a standard as part of IVF? Because that was part of one of the questions earlier. It said, why isn't this standard? So Àlex, would you mind answering that? And then we'll ask Dr. Tsakos to answer as well.
Well, I think that we always need to tell patients, on each single patient, that this is a standard, or could be a standard and could be an option. Not because we could get legal prosecution, that's what's happening in the US, that you need to tell the patient that PGT-A exists, even if the patient doesn't need PGT-A, because if you don't, and there is the birth of an abnormal baby, you can get in jail. So that's the American model. And I'm happy that in Europe, this is not going to happen. But not because the risk for the clinician, but for the risk of the patient. We need to be true and tell IVF is standard, PGT-A is a standard. Do you want to do it, or can you afford it? And I think you need it, or I think the risk or the benefit of undergoing PGT-A is not worth it, from an economical point of view. But I think that PGT-A is becoming a routine in several clinics and several countries. Even in egg donation, some clinics will report up to 50% of PGT-A. That might be excessive as a clinician, but probably it's not excessive for each single patient that had the consent form and decide that they really wanted to get the benefits from PGT-A after getting all the information.
Okay, thank you. Justice Tsakos, what would you say about, I know you've already said about Greece and you've got limitations on how you can use it, but if you kind of generalize a little bit, speculate. I'm not asking you to put your neck on the line, but what do you think would change how PGT-A is offered in terms of making it more of a standard? I'm not saying that's the right thing. I'm just saying, how would that happen?
Sure. I mean, I would like to address a little bit the issue of and the technology of non-invasive testing. I think there is a place in that, and not only because my team has been involved in a wonderful multi-center study that was presented in ESHRE and hopefully now will be published in the Fertility Sterility, but I think that 90% is pretty good going. And I think there is a tendency in medicine. I agree it's a surgical procedure, it's a microsurgical procedure. And as a surgeon, as a background, I can say that the tendency is to move to non-invasive or to less invasive surgeries. And we've seen this with laparotomies moving on to laparoscopy and then moving on to robotics. And we've seen it with amniocentesis and then moving on to non-invasive prenatal testing. So my feeling at the moment, my scientific hunch is probably saying that non-invasive testing is here to stay, and maybe will be complementing invasive PGT-A. And perhaps if we all agree, and I'm very happy to share today my relief and my joy that our esteemed colleagues like Dr. Faura, like Professor Gianaroli, like yourself, we agree on principle. I think if the scientific community, at least on this side, on this part of the world in Europe, if we agree on the place of genetic testing, whether it's non-invasive or invasive, it doesn't really matter. I think at the end of the day, our patients will benefit from that.
Okay, did you have anything to say about the cost? Because thank you for giving your non-invasive answer. That was, that was helpful. Is there anything you can say about cost, or is it just about getting more consensus, more publications? Because we've been doing this for 20 years and it's not standard.
I would point out the value, and I would definitely try to address the indications, and those indications have been really mentioned. So for those patients where there's a clear indication, this test is cost effective, absolutely cost effective, because the worst that can happen to a patient, in my opinion, is not just failing the IVF. Is dropping out of the IVF program altogether, is having a dire complication, because aneuploid abnormal embryos can still cause a corneal pregnancy, they can still cause an ectopic pregnancy, they can still risk the integrity of a woman's uterus, and they can risk the inability of not having children in the future. So cost effectiveness, I would focus on more than actual cost itself.
I just put that question up because actually you've sort of answered it, whether someone should transfer an aneuploid embryo or not. We won't go into the details of the chromosome. All I would say to that person is, if you felt very strongly about it, I would have a discussion with a genetic counselor to look at the results in more detail and see why you want to transfer that embryo. Àlex, I think you had something to add.
Yeah, of course. Next step, and I'm sure we will see it, even if we are not the youngest in the clinic, but I'm sure we will see this robotics applied to PGT-A and any other micromanipulation techniques. And of course, as Luca said, it's not only the technique, but it's the one who's doing the biopsy. And now that everything is managed by micromanipulators, probably in 5-10 years, you'll say, yes, I want my embryos in Barcelona to get the biopsy done by this biologist who lives in the USA. And this biology will be at home with the PlayStation, just doing the biopsy to my embryos in Barcelona. So this might reduce or increase costs depending who's gonna do the biopsy and how many embryos you can do in one single day staying at home. So of course, robotics will get in that field, and it might reduce or increase costs. We still need to see what's going to happen with that, but I'm sure we're going to see it.
Okay, perfect. And I think you've not inadvertently done it. You wanted to make a point. It sort of answers this question: do labs have the capacity to do these tests for every IVF? And I would say today, probably not. and a lab that already isn't doing much PGT-A is going to struggle to do a lot more. So we need automation, robotics, and everything else. I'm going to give you one final question, gents, because this is relevant, because you both put your neck on the line and said we do a lot of ICSI. So somebody has asked, which is a great question, what's the benefit of doing ICSI if there's no male factor? So if you can keep it really brief, like 2 sentences, if you can. So we'll start with Elias, and then we'll go to Àlex, and then we'll close off the session. Thank you.
Basically, it's male factor is not the only indication for doing ICSI. I mean, that's the bottom line. And also, we've all experienced, I mean, I'm talking about myself, I've been around for more than 30 years now, and I have got very fresh memories of failures, of unexpected fertilization, failures, of not having enough embryos to transfer after difficult stimulation and so forth. So I think there's a lot more indications for ICSI than male factor. And nowadays our patients tend to get older, much older. I mean, the average age of our patients with own eggs in my clinic is very near 39 years old. So we cannot risk poor fertilization or no fertilization, and then only to find out that, okay, now we have to repeat the cycle. Also, I mean, the patients come to our clinics for the best possible outcome. And I think that securing, you know, if you dig deeply, you always find an indication in ICSI, and if not always, invariably. That's my view.
Okay, thank you. Àlex, do you have anything, if you disagree with that, say so, but do you have anything to add to that?
Well, I think that finally each lab has to decide how it works. And of course, when you get to the ICSI routine for every single egg, and you get all the lab in this routine, I know that when we get sometimes 25 or 35 eggs from a patient, the biologist might want to kill me. But of course, it works. And we know in our clinic, in our lab, it's the way it works. And we do have an extremely high fertilization rate during ICSI. Of course, in some patients, I'm sure that IVF would work, but ICSI too. So that's why probably we're doing ICSI. It might be a little bit more difficult. It might take some time from our biologists, but it's the routine that we got into the lab, not doing IVF and ICSI. We only do have ICSI. It's easier to get in this one single routine for the whole clinic, and it works. So I think that's the main reason. And I'm not telling that IVF might not work in patients with where there's not a male factor. Is that what we decide in our lab?
Yeah, perfect. Very short, because I want to let you both go.
Yeah, I mean, I fully agree with Àlex, and I would just add that in my personal practice, the biggest relief was when we introduced about 10 years ago the fact that ICSI is not paid extra. So since we've done that, you know, we felt the relief that our patients understand that we're going to give them the best possible outcome without risking the individual patient, the individual couple, which in my opinion is a good proportion of our population with abnormal fertilization or no fertilization with IVF. So since we've done that, to be honest, I can't remember a single patient or a single couple who said, oh, okay, I know it's included in the price, but I would prefer if you'd done IVF on my eggs. I don't know if Àlex has similar views. So it was a huge relief when we managed to offer this as a free service for our patients.
Okay, thank you very much. Thank you for your very open and honest answers. I think that's been really instructive for everybody here, including us, including the panelists. So it only remains for me to thank everyone for turning up. Thank you guys for contributing so fantastically. Thanks for Ask Your Doctor for putting this event on, and we look forward to seeing you in the future. Please don't forget to answer the question in the poll, because answering those kind of satisfaction questions are what drives this to make sure we do more in the future. If you have any suggestions about what topics you would like us to cover in the future, please let us know as well. So thanks very much, everybody. Hope to see you all soon. Bye-bye.
Bye.
Bye-bye. Take care.
Bye. Take care. Bye-bye, everyone. Bye.